Good day everyone. Today guys, let's discuss about the common documentations that you will definitely encounter when you arrive here in the United States. This is part of your everyday routine per patient. So I'll give you an example of a task list and the kind of documentation that's stated there. And I'll just give you a brief sample of what we normally do and how we do things here. So if you see the entire picture, you see there's a scheduled time here, the next scheduled. These are the documentations for a day shift. See that? It's due at 7 a.m. and the next one, it's 1900 hours, which is for the night shift. Okay. Then you can see the frequency. Then, of course, the intervention, the name of the documentation. Then, what else can I say? So basically, this one that has a number or that's scheduled, these are the things you have to do per your shift. And the bottom ones are usually PRN documentations where you only have to document if you need to use them. Okay, so it doesn't mean everything's there. You have to do everything there. Nope, most likely just the things that are scheduled. And fortunately, in this particular system, we don't really have to do everything like one by one. Here, we can just do a drag and paste on the next one, and we just tweak and edit, which is really faster. Unless it was an admission, then you have to do it from the start. Okay, so anyway, let's start from the top. Here it says telemetry monitoring assessment. It's every shift. And it's actually scheduled at 7 in the morning. So if a patient has an order for telemetry or to be placed on a cardiac telemetry, it's usually like a leads. It's usually like 4 to 5 leads. 1, 2, 3, 4, 5. So what we do is we have to apply or put the monitor on them, and someone will monitor their heart monitor from a separate room. Usually a teletext or someone assigned to watch their heart rhythm. They usually just call us if there's something wrong. Example, if the patient's heart rate was like 140 or 130, he or she will give us a call and tell us that the patient is having an AFib or a fast heart rate. Then what we do, of course, we have to go to see the patient and check it ourselves. So that's really a basic thing with telemetry. But not all facility has this kind of system. Some of them you have to monitor on your own. So fortunately for me, for my last 2 hospitals, someone is monitoring for us. Some few things we have to do here. For the telemetry, we have to make sure that the leads are attached to the patients. Sometimes it gets fall off or the battery gets low. So we have to monitor this as well. If something happens to the monitor and it's like a low bat or one of the leads goes out, teletechnicians will tell us that the patient's lead has fallen off or it's not connected to the patient, or it has been like a low battery. So we have to switch the batteries. And also, in some of our telemetry, it's also connected to our SpO2 monitoring. So we usually use this if patients are really like wearing oxygens or on BiPAP, or in a case wherein saturation will be a factor for that patient to be monitored. The next on the line here is the hourly round assessment, and it says Q1. Yes, we have to monitor our patients every hour. But in our facility, and those 2 hospitals I've worked, you have to only do like the even numbers or the odd numbers, because your tech or your CNA will be the one to monitor the opposite number. Example, I will monitor the 7 a.m., 9 a.m., and 11 a.m., and my tech will monitor the 8 a.m., 10 a.m., and the 12 noon. So and so on until the end of the shift. So that's our role on how to monitor the patient. This is meant for patient safety, definitely. Normally, what you can find here is the patient's position. If patient has any urge to urine, or you offered any assistance for the patients to like for eliminations, or how his position is. If patient is in pain, the patient's bed alarm is turned on. Or if the patient has any pull-away alarms. If something happens, like for example, a patient fell and it found out that you did not turn on the bed alarm during these particular rounds, then you can be liable for that. Okay? Because it is your responsibility to make sure that these things are on, especially in your hourly rounds. So you should not document just because you think you should comply with this particular hour. You should monitor whatever it is applicable for the patient. Okay, so this is one of the documentation that your manager will look at if ever something happens to your patient, particularly if they fall. So they have to look back at this. And you have to make sure that whatever you documented is correct and accurate at the time. Because if the story doesn't match and you just like documented just because you want to document it so easily, like copy paste, then you might be liable for falsification of documentation, something like that. Next will be the advanced directives. This is just basically to ask what kind of code status the patient would have. Example, full code, or DNR, or DNI, or both DNR, DNI. So we have to know that. And sometimes we do have more specific things here if patient is organ donor or if patient is an advanced directive, or especially those who are not mentally in the right mind. This is where we put in the POA or whoever the guardian is, or any emergency contact number. So this is one of the things that we use. Just make sure the status that the doctor plays for this patient. For example, he plays that the patient is a full code. Then when you ask the patient, he or she wishes to be on a DNR, DNI status. So these things should be matched, okay? So if there's a discrepancy, you have to tell the doctor that the patient wishes to be on a DNR, DNI status. The next, one of the most common forms that you will definitely encounter, which is the Morsefall scale assessment, okay? So this is really common. So one thing I can give tips about this is, please read everything, okay? It will be hard at the first time, but after doing it like maybe a couple of times, you don't really have to read it. You just have to score. The score is, by the word itself, is something to do about the fall. It categorizes the patients to having like a fall, low risk, medium risk, or high risk, depending on the conditions that are met there. So you just have to tick or score them depending on what they label and add them at the bottom. Okay, so you have to meet the criteria for this, and each conditions have their own precautions on what to apply. For example, if a patient is a high risk patient, definitely part of that plan is to turn on the patient's bed alarm, make sure everything is whatever the patient needs is within the reach for the patient, on the table, those kind of things. As compared to a patient who has low risk, we don't really have to do much for him. We just have to advise a full risk and nothing intervention much, because like for example, I'm the patient and I'm like a walkie-talkie independent, so I'm definitely not a full risk. So you don't have to put much restrictions for me or much precautions for me. Then the next will be the VT or DVT risk factor assessment or score. So in summary, these things will have a scoring system. It has like a few conditions and we'll check if you are getting a score for that. Example of conditions here. Example, a patient is taking like any estrogens or any pills that can cause clotting, or patients who had a history of cancer or getting cancer treatment, patients who had a history of DVTs or PEs. So those things take into factor. If those conditions are met, they have like a 1 point, 1 point, 1 point, 1 point. Until at the bottom, you'll reach a certain number. If you are a high risk, then definitely you have to do something about it. But most likely our doctors would be like on top of this and they will order appropriately. So like in our hospital, we normally have heparin subcutaneous that we're giving to our patients every 12 hours. Depending on their weight usually. But usually it's 12 hours and it's 5,000 units subcutaneous. So that's one of the things. Unless if patient is taking any other blood thinners like Eliquis or warfarin or Xarelto, so these kind of things. So we have to make sure that we have some precautions in order for them to prevent having blood clots or spreading the blood clot. Then the next is a daily adult system assessment. Here basically you're just assessing your patient. It's usually from head to toe. In previous documentation system that we were using Cerner. It was more detailed about the patients. You can really find like per system, neuro, respiratory, gastric, skin integrity. What else do we have there? Psychological and more detailed. But on this system that we're using right now is an old version of Meditech. There were fewer. Just like GCS, patient's respiratory rate, cardiac system, gastro, and not much on other things. So just the basic things. Other things like fall on different forms. So in general, just assessment of your patients. So it might sound overwhelming. The easiest thing you can do here is get a copy of that or screenshot of that or print that off and learn what those words mean and try to apply them on your patients. See if they are applicable. As easy as that. Okay, you just have to go by like doing research on the first month that you're here or first few weeks, and definitely you'll get used to it and you might not have to have this considered a problem anymore. It will be like an easy peasy for you. Then next, of course, is the vital signs. Usually for ours in our hospital, it's usually like Q4. We only have Q shift if patients not really, always really like quite stable. The frequency changes depending on patient's conditions or the doctor's order for this. But normally for the floor, we only stick with the Q4. Unless we have to do like a vital signs for blood transfusions or hourly monitoring for those post-surgery. So these things changes as well. Then of course, intake and output and height and weight. For the intake and output, whenever we have someone who like pee, we just document it immediately. That's one of the tip I can give you. Document as you go. So at least you won't forget and you have more accuracy on that. So here we document like what we normally document, like oral intake, or if there's an NG, we get an NG intake. We get the flushes or the fluids, IV. For us, for the IV, we have to clear our pumps at like 6 a.m. for the night shift, or for 6 p.m. for the day shift. So depending on the protocol. But most of us do this more earlier. But by protocol, we have to do this like 6. Then for the height and weight, normally we get this during the start of the admission. We have to have like proper initial height and weight. Then after which, for the daily weight, we have this case wherein if patients are taking Lasix or has history of CHF or like something about swelling or that can have a drastic difference in their weight, then we have to monitor them daily. So like in our facility, it's kind of strict that we have to check them every morning before breakfast. Next ones are the miscellaneous nursing orders. So some of the doctors will do a freestyle order in order for them to put it here on our intervention list in order for us to take note about the things that they want us to know. Because some of the things that they want to write are not found on the available category for the documentation, so they just have to do this, and it has like specific instructions which are located on that small bubble over there. The next will be the review POC or point of care treatments and services. Yes, we have to do this every shift. We have to check for the patient's histories, orders, for the medications, for the specific instructions that the doctor has placed for that patient. We have to make sure that we know. So this is one way for us to acknowledge that and that we are doing this. So basically for us, this is just like a way for us to acknowledge that. It doesn't have really any content in it. We just have to click on it and click yes. Then next will be isolation. Our patients, if they have any history of like infectious diseases or they are in the reverse isolation, we have to include this in the intervention. And yes, we can add interventions which are fitting for the patient. So like for this patient, has like a history of CRE. So we have to put in the intervention of isolation in order to notify that we are patient is on isolation protocol. The next will be the effect and teaching of medications. This is like an old school thing, but basically just have to know the medications that you're taking and you give your patient instructions or educations about the medications that you're giving to them. About the name, dosage, the rate, side effects, adverse reactions, and those kind of things. The next will be the adult peripheral line assessment. So in other words, your IV line, peripheral, okay? So you have to monitor this every 4 hours. That's our protocol here. Every 4 hourly. You have to make sure that the line is working, that it's not swollen, there's no signs of vulvitis, no signs of any swelling. If there is, you have to document that. Or if patients are complaining of pain, they have to document that. If the patient has discontinued that, you have to document that as well. If you place a new IV, this is where you put in those details on what are the things that you use for that patient. For example, you place a gauge 22 on the patient, which arm, how many times have you inserted, did you use a proper gauze, use a proper solution, do you use a dressing, and how does it look? So those basic kind of things. It sounds complicated, but it's really not. The next will be the discharge planning assessment. Normally for us, we don't really do this like really every shift. It has a lot of documentation they have to put in. Normally, we do this on the day the patient has to be discharged. We just have to fill in it partially just to make sure that we know where the patient is going home or what's the plan for this patient. So here we put in the time and date the patient was discharged, instructions given, vaccinations, follow-up, or how the patient left, is either with ambulance or private cars. So these kind of things. These things are very easy to fill up. They're like basic questions about the patient on what happened to them during the discharge process. The next will be the activity or /ADL or activities of daily living. So here we just basically document what we did for the patient or how the patient like acted during the day. So for example, bedbound patients, we have to put in there that we did give a bath or we cleaned the patient, we did an oral care. What else we put here? If a patient is like a 1 or 2 assist, patients were able to walk. So we have to put there the assessment on how the patient acted during the time for that particular activity. So this is very basic as well. The next will be the pain assessment. By the word itself, we have to make sure that we are asking the patient's comfort. And if patient has any pain, then we document this here as well. So just to have the more details about the patient's pain. The next will be activity ambulate. So here normally we document how patients mobilizes. For example, they're using a walking frame. If they need a one assist, how far did they walk? Because some doctors would prefer knowing those things, particularly patients who are like doing therapy. So they would prefer that patient has actually ambulated this particular shift. Sometimes they do encourage and they want this to be documented here. The next in line, I think we're done with the Q shift. Now let's go for the PRN. Next one will be the fall suspected fall assessment. If your patient had an incident of fall or suspected fall, then you have to fill this up. Just like the details, what happened, what transpired, how the patient fell, is there any injuries? So it's kind of like an IR also. But honestly, aside from this, we have to do more on a different program here. So there's more documentations wherein you have to call the family, inform the family on what happened, call the doctor, what time you called the doctor, what interventions you did, you inform the house supervisor, what are the instructions to do for this patient, and those kind of things. So we have to do a lot of documentations once your patients fall. So definitely you don't want to have your patients fall. And the best way to prevent this is doing preventive measures. Okay? So you have to make sure that these things are in place in order to avoid doing this unnecessary stuff, even in the case your patient falls. Other common here is critical values verified. This is very common. So if you have a patient who has a critical value, critical means, example, you have a potassium level of 2.6. That falls under the critical low level. So that's what I mean by critical values. Because sometimes your patient's potassium says like 3.0, it is low, but it's not considered a critical level. So if ever your values is under the critical value range, then you have to inform the doctor. In our particular hospital before, you have to do this within 20 minutes after the laboratory has informed you this. So the lab also documents on their side that they had called you and documented the time that they informed you about these labs. And you have to document this as well, that you inform the doctor or what the doctor ordered for this particular critical value. So that's very, very basic and very common that we do every day, especially for the night shift that we normally get lab results before 7. So we do a lot of calling around this time, informing our doctors. The next will be the S bar. So for here, we just document this whenever we have some issues that we just want to protect ourselves. So we put like certain scenarios in these particular documentations. We don't necessarily do this every shift. Believe it or not, we don't have any like documentations like what we normally do in the Philippines. We have like, those long documentations like a paper charting, like a storytelling about those things. We don't have those documentations. Our documentations is mainly this intervention list. Okay, so not much about like a narrative kind of documentation. The next will be the high-risk medications verified. For some medications, for example, I think in our hospital, if we have heparin of more than 5,000 units, we have to have someone verify that with us. So we have to find a registered nurse and tell him or her that we are giving this medication. He or she should witness and he or she should document that she has verified that we are giving it on a safe dosage. Okay, that's like for heparin shot subcutaneously. Then another example is for heparin as well, for those given IV infusions. So whenever we change the drip or we have to adhere with the protocol, we have to get someone to verify that with us. For example, if the patient's APTT came back that is what like it's like 30-40, then we have to check the protocol, and the protocol says to increase this to 300 units plus a bolus of like 4,000 units. It's just an example, okay? So we have to get someone like a licensed nurse to come witness us and do the adjustment and document that on their system that they have verified what we are doing. So this is meant for the safety of the patient while giving high-risk medications. High risk means, of course, that can kill the patient, can cause harm to the patient. So there should be like a second nurse. Then sometimes if a patient has a central line, we do monitor them like Q4 hourly as well. It's the same thing with the peripheral line, but it's a version for the central line. It's either a PIC line or a Mediport or a trialysis catheter. So this kind of line that we normally use. The next here is the in and out catheter assessment. Here, when we do an in and out catheter, we don't really have to get an order. It's either a guy or a lady. We just can do it if we need to. But it comes to Foley catheter and needs to be anchored, then that's the time we have to get an order. But of course, before doing the in and out catheter, you have to have meet certain criteria in order for you to do this freely. So like I said, this is just like a simple documentations or a summary of what kind of documentation you might encounter when you start working here in the United States. This might have a different version, different name, or different style, but most likely the essence will be there. I used a Cerner before, I use a new version of Meditech, and I use an old version of Meditech, and all three of them has similar function, okay? Like what most of the travel nurses said, nursing is same wherever you go. Is the protocol, the system, and how things are being managed. The only things are different. So if you are a new nurse here in the United States, definitely you have to have some adjustment. You just have to work on it, try to figure out what to do, learn these documentations, and definitely you'll be okay. It might be overwhelming from the start, but definitely you'll be able to adjust with these things. You just have to work smart, not harder. So if you like this video, please click the like button, subscribe button, and please share it to your friends. Again, I'm Nurse Juan de la Cruz, your OFW nurse. Thank you for watching. God bless. Bye-bye. See you next time.